Welcome to All Systems Ergo, a human factors and ergonomics podcast delving into the fascinating world of healthcare. My name is Fran Ives and I am a chartered human factors specialist. I'm naturally curious about people, and throughout this series I want to explore different areas of healthcare human factors and the people who work in this diverse discipline. So far in this series of All Systems Ergo, I've spoken to human factors specialists undertaking a variety of different roles in healthcare. So today I'm shifting things slightly as I have two clinicians with me. I'm really pleased to welcome Dr Neil Spenceley, Clinical Director at the Royal Hospital for Children in Glasgow and a paediatric intensivist by background. And also joining today is Dr Carl Horsley, who is also an intensivist working at Middlemore Hospital in Auckland, New Zealand. So welcome to you both.
Thank you very much.
So a lot of conversations I've had so far in this series have touched upon the small number of qualified human factors specialists within healthcare. And I think it would be really remiss of me to complete this series without exploring some of the ways that human factors is applied in healthcare by people such as yourself. So people who undertake a variety of different roles, in your case, you're both intensivists, but contribute a huge amount in terms of human factors. So I'm really keen to know a little bit more about how you do that. So an open question to you both, really, to get us started, is where did that interest, that passion for human factors come from? And then further on, what does it look like when you apply that into your organisations?
I think for me, I'm not trained in, freely admit, I'm not trained in human factors, but I've had an interest in it and the way that systems work positively for a long time. In fact, I can tell you almost the minute that I had an epiphany moment. It was at lunchtime on the 12th of September 2014. And the reason for that was that I've always had a deep interest in people and a deep interest in the conversation. And I've always found that going to speak to people within healthcare is the thing that actually makes the society work. And I think PICU, Pediatric Intensive Care, is a society. It's an ecosystem that needs tended and looked after and loved. And I've always been very aware that it's been highly successful. And it's the connections that you have with people in order to that makes that successful. But I've always worried about the stuff that goes wrong and the enormous amount of dedication and time that it's taken to look at things that go wrong. And I've always wondered about, but it's always that successful that we don't look at that. And I was at a risky business conference, and the risky business conference was run by two pediatric intensivists, Alan Goldman from GOS and Peter Lawson from Toronto, now back in Boston. And I freely admit I was quite hungry, and I thought I'm just going to nip off and get into the queue first for lunch. But there's this guy going to talk to me about resilience engineering, and I don't really know what that was, and things about success. And I was moments away from leaving my seat. And on wandered this chap and apologized immediately and said, "I'm the person keeping you from your lunch." And I thought, I'll sit here for the next 2 minutes and just see what he's like. And it was an epiphany, because this was Eric Honagel. And he talked about the way that we view the world, is possibly blinkered, and the way that we should be viewing the world through a different lens, a different eye. And the fact that nobody looks at successes, and that in healthcare that we don't look at in that way around. And that was my sort of real epiphany moment. Actually, you were talking the same language as me, and this is something that we should be, looking at. And he was very interesting because he was talking a little bit about QI to a certain extent. And then he was almost talking about the special cause, in QI, the blip above the standard deviation, and the things that we look at and we concentrate on and we worry about and we invest in and we create anxiety and pain and shame. And he said, but the bit between the lines, sorry, there's a plane going over, the bit between the lines, the natural background resonance of your system, nobody's looking at that. And that is the everyday success of how things actually work. And then that's kind of where I kind of got into the sort of the idea of the societal element of intensive care. There's very little evidence in intensive care, and yet our outcomes are hugely successful. And that was, kind of my epiphany moment, where we're potentially should be broadening our lens. And how do we make the everyday, particularly the nurses who are the glue of the organization, how do we make their lives easier every single day? So that was and it's interesting because it just struck a chord with me, and as I say, it's always been something that I remember when I was a medical student, I was nearly failed for my medical attachment by this Welsh guy who I won't name, but he says, your knowledge is terrible. It's appalling. And I went, right, okay. And I was going to fail you. But the registrar said that you have got something else. You have got the capacity to speak to people, to notice things, to engage with people, to bring people together, to do these types of things. And I watched you doing a ward round with her, and I agree. So although your knowledge is utterly terrible, I'm going to pass you. And so don't forget to try and develop that, because I think that's your sort of vague secret skill. And so that's kind of where and we can go on talking about my, the stuff that I do on the wards about getting to know people better, getting to understand their work and how to make their work easier, and how I can make their work more difficult sometimes. And I hadn't realized I was doing that. So that's a very long-winded answer to what was an extremely short question.
But that's quite an epiphany, and I'm quite excited to hear whether Carl had also such an epiphany, or whether he has a different.
I'm kind of in reverse. I was a reverse one. So when I started doing ICU, I was went to the ICU that I ended up working in, and I was kind of in charge of trying to make it safe for kids in a mixed ICU. So trying to work out how do I support staff who are used to dealing with adults to deal with kids down to sort of 3 kilos, and how do you provide supports? What are the tools and artifacts and things that I can do that help to design that? So thinking very much about that kind of, how do I support people to do good work? How do I create these systems around people to support them? And from there it was into, the usual trek into simulation, and from there into then I ended up talking to Eric through the simulation stuff, and so came to Resilient Healthcare Society, and then on to formal study in human factors and system safety. So for me, it's a reverse thing, which was it started off grounded in the realities of everyday work and how to design systems to support people, and then it sort of carried on up to more the sort of system ergonomics kind of, how does the system as a whole come together to support the work? So now involved in kind of governmental level, governance about how do you create the capacity of human factors training, how do we, show the value of that. And so I think for me, it started off grounded in the reality of everyday work, and it's kind of remained there in some ways, but with these other layers about seeing the rest of the system as well.
So, Carl, how have you managed to sort of take that continued learning and integrate it into what you're doing, and combine the two?
I mean, the good thing is once you start thinking in systems and start seeing people in systems, you can't unsee it. So for COVID example, we weren't there to design a process and a policy. We were there to play with what does it look like looking after sick people wearing PPE at 2 a.m, when everyone's tired with new staff coming in something that might be at risk to us and our families, and what are the structures around that. So for us, it's kind of that way of seeing the world of people situated in systems has become sort of part of our everyday way of thinking about clinical work. And how are the tools affecting the way we work? What are the how do we design those better? So it's become really a practical thing amongst not just myself, but a whole team of us within our unit. And we're not dedicated HF practitioners, but we kind of have that lens of, okay, so how do we support people to do good work and to make work better? And I think some of that's cultural, as Neil says, about looking after people, being curious about work, and creating that space where people can be vulnerable and share what the realities of work are like. And as you know, in HF work, it's very often that combination of curiosity and vulnerability is really where you get to understand work is done, and to work, to centre work as done and the realities of that. And when you're thinking about how to design systems to support people. So I think that's not too hard. And I think for most of us, like for Neil and I know we both talked about this, is that some of that for us as clinical leads is we're not like an HF practitioner that comes in and does a good design and then works away. We're there every day. We can reinforce and pay attention to different things. The way we use language to create space for our teams to work effectively, to feel valued, to understand what's going on, to come to us with, ideas, innovation. So I guess one of the joys is, when you, although you may not have the same technical depth of knowledge, you can still bring that viewpoint and that lens and that way of seeing the world to every clinical interaction, to every non-clinical kind of interaction. And you can shape your units to be aligned with those kind of principles about supporting people and the realities of work, to enhance system performance and human well-being. That's kind of a given, it's easy.
I think that's a really interesting point that you've made, Carl, about you're there every day. So everything that you do has that lens and focus. And so every day and everything you do, you're constantly reinforcing the human factors principles that you work by. When you're a human factors practitioner, and very likely the only one in a hospital, you will be placed in any number of different departments. That, in a sense, is almost irrelevant. The tough thing is that you're often the only person, and you're going in and out of departments, doing bits of work, which is brilliant because your job is endlessly fascinating. No 2 days are the same. You can go to any area of the hospital, which is an absolute privilege. But what it does mean is you go in, you do that project, that piece of work, and then you come away again. If you've done a good job and you've established those relationships, you'll often be asked in again, and that's brilliant because you know that they valued your work, but you're not there day in, day out. You just can't spread yourself that thin. So the idea of that sort of every day becomes language that is really commonly used. You talked about giving people that sort of space and that psychological safety. That's something that takes a lot of time and a lot of effort, and is probably much, I would imagine, more easily achieved if you are there day in, day out, rather than a human factors person sort of sailing in and sailing out again. Neil, what's your experience of integrating human factors into your own department and perhaps beyond?
Well, I mean, I think that what you've touched on about the societal element of it, the psychological safety, you never have enough information to make the snap decisions there and then that we often have to do within intensive care. But I think, as Carl's said, having that sort of visibility and demonstrating vulnerability then can create, I suppose, a situational dependence. And you told me about this, Carl, the sort of the words and deeds that make differences to people's lives, and also creates, I think, that creates the trust element within your society that then gives you the information, good and bad, that you need in order to make the best decision at that point, recognizing that you have an outcome in mind rather than the actual outcome that is eventually occurs. I think for me, the things that I've done in the unit are to do see what the gap is between work as imagined and work as done. And I've done quite a lot of nursing shifts and cleaning shifts and portering shifts within the intensive care unit, and that was a total an eye-opening moment. And it really did show me that there's a huge difference between work as imagined and work as done. I imagine I knew what the nurses did by the bedside, even though I saw them every day, I spoke to them every day. But it turns out that I don't, and I didn't. And I didn't really have a clue until I did some nursing shifts. And it's remarkably different how how they function every day, and also how I could make their lives worse and more difficult, by wandering in at a time of my choosing, not theirs. Telling them the 4 goals that we should achieve when I come back. And again, I'll be coming back at a time of my choosing, not theirs. And what I hadn't realized was the goals. When the team came back the first time that I did a nursing shift, we had achieved 3 goals, and it was stunning how we focused on the one goal that we hadn't achieved. But what they hadn't seen was the 250 other goals that had been effortlessly achieved during the day, despite the fact that you couldn't find the drug keys. We'd run out of tea bags. There was somebody went off sick. There were 2 admissions, and all these things that, and they had effortlessly adapted to the ever-changing conditions of work, and we hadn't seen that. And I in myself could have, been imposing conditions of work which were more constraining. And in highly complex systems, we are, I think, tending to stray towards trying to control it because we don't know. It's a frightening thing, complex systems, and we try to control it, but in fact, we compress complexity. And we come up with sort of things that are incorrect. We provide a solution like a protocol or a guideline, and it makes more difficult the work. But in fact, in order for ICU to work, to solve things, you need to involve and devolve. And I kind of realized that actually the way that I construct the ward rounds now is that the nurses will tell me what to do and what they are going to do, because they're standing beside the bed for 12 hours. They were standing beside the same bed 12 hours yesterday and the day before. They've noticed the nuances of change. They've noticed how things are getting better or worse. They know what works. They know what doesn't work. They know what the parents need to know. They know what additional information they've got from the parents, which is useful for us. So I think the workers done shifts have been again in a sort of another epiphany, and I think that also gets you to realize what the nurses do, how they function, how best I can help them to work effortlessly and have more time to care. And then it does create that sort of situational dependence that I think that they will come to, me with problems that are maybe, that are causing them more worry or anxiety, and they will volunteer information that I need in a timely manner. I always remember Dave Hallworth was the guy who gestated our unit many years ago in the old hospital, and we had these critical incident meetings, and I'd never been to a critical incident meeting before. And you used to have the bits of paper that you just wrote out stuff and then stuffed it in a letterbox, and then we talked about it at the end of the day. And I was chatting to somebody in the hospital the other day, and then he was saying, well, gone are the days of the Dave Hallworth discussions in that wee room at the bottom of the corridor. We have to have much more robust processes for investigating and things like that. And I was reflecting on that the other day, because we sat in this wee room, we discussed all the cases. We made no decisions at all. We changed nothing, ever, But I realized looking back what he was doing is that he was creating a safe environment for open discussion. And that when things did actually become really problematic, and I remember a couple of times when I thought, I have really screwed up here, and I could maybe get away with it, but actually Dave has created an environment where I can go to him and talk to him about it, and able to volunteer stuff which was worrying me about patient care that I had been involved in and I had done. And looking back, I now realize what he was doing. He was creating situational dependence and psychological safety, even though those terms weren't obviously involved in that point. But in doing so, he was getting more information about how his unit was working from different sets of eyes, from different people, all who have different, skills, gifts and passions that he needed to integrate and absorb and use in order to make the unit function. So I was on the talk the other day actually with Steve Shorrock, and somebody asked me, said, what one thing would you do or advise people to do in their unit? And I said, go and walk in somebody else's shoes. Because the information that you get from that is extraordinary, but the communication that you get after that is even better.
What surprised you most about spending time working with those other professions, the nurses, the cleaners?
How unbelievably relentless it is, how incredibly hard it is, and that never has a cup of tea tasted so good at tea time. But it's constant. You can't leave the bedside. You have got so many things to look after. You have got technology, which we think is going to make an enormous difference, bringing in more and more technology, which actually can be more and more distracting. We think that putting more information into our clinical information system is going to make us safer, but actually it removes time to care. Whereas there's all this sort of documentation and things that we have to, and tick boxes, etc. That we think makes us more safe, actually might just remove the capacity to observe the child. It's interesting, sometimes we've got a very clever clinical information system, and sometimes I know that the fellow in the morning, because they're busy, has done the report and the handover from the clinical information system, and I go and actually see the patient, and I think these are two entirely different sets of variables that I've been looking at. The patient looks terrible, but the chart looks good. And it's kind of dislocating, I think, sometimes. The things that we're bringing in sometimes can dislocate you and distract you from the patient. So that was one of the things, the amount of documentation that the nurses have to do at the bedside, when actually, and also the other things is interpreting our decisions in layman's comforting terms for parents. And the parents are there, they're obviously worried, anxious, scared, and that's another sort of another pressure that they have, that they have to cope with. So it was the documentation, it was the relentless nature of it, it was the distractions that we could create, it was the things that I would maybe ask which were unrealistic, and all these things that it's almost trying to think, how can I make things much more manageable for them. So if I was going to do a couple of other things, I would, so the nurses will now tell me what to do. I think we need to simplify the technology that we've got, so that they can minimize the documentation, release time to care, and also articulate stuff which is going to be articulatable to parents as well in a consistent manner.
It's a really interesting thing, just what you're saying, Neil, about the technology, because I kind of feel like often we hear technology, this kind of techno fetishism at the moment, and ICU is a place of great technology, but it's taking that time to sort of think about, what does this add, what functions does it create, what are the assumptions built within this change. We see this with the paper documentation to electronic documentation, where people presume it's not going to affect the way people work. Or we see it with Pyxis machines with computerized medication dispensing, that it's altering the flow of people's work in the wards. On the unit, you see more queuing behaviour because there's a single point and got standardized times. So these kind of secondary, I think that's one of the things when you have an HF lens or a system lens, you're constantly looking around to see, what are we trying to do here, and is this moving us towards that purpose? You talked about care, is it moving us towards care, or are we just doing it because it's, the flavour of the month, or it's new, or we're rolling it out everywhere else? So I think one of the great things with, if we think about QI versus HF, QI, a good QI is always focused on curiosity and being at the bedside and co-design, but its roots are industrial on efficiency, whereas HF its roots are on well-being and system performance. They're different sort of backgrounds. So that fundamental thinking about, why is this so? What makes us do this paperwork? What makes us design our systems this way? What do we pay attention to and why? What drives that at a higher system level as well? And how do we influence that? So I think when you're talking about the HF, it's that lens on thinking about the way that our system design influences the things we want to achieve: good care, working in relationships, feeling valued, having tools that make our jobs easier and can tell us when things are unexpected. I think all those things are central, and that kind of design element, I think, is often missing. We haven't thought about, why is this so, and how can we make it better?
And you've both talked about being able to apply that HF lens within your own departments, and I've really seen the value that you can bring. How much is HF talked about and integrated beyond your departments? And Carl, you talked about, looking at system design and what things are working and aren't within your own department. If you were to identify something that just wasn't working and hadn't been designed with a human factors focus and something you really wanted to change, how easy is it for you to sort of go beyond your department and actually talk that language?
So, I mean, I think there's a few things going on. I think it is the sort of age of HF in healthcare is coming. You look at the WHO patient safety strategy, HF is explicitly within that. In our own national work, we've, been working with the Human Factors Society and our health and safety regulators and our national insurer to sort of look at, how do we create a pipeline for HF training? So I think, at the moment, it's really hard to go there and say there's a system problem here. We need a proper HF practitioner in to look at it. And I'm sure it's the same in the NHS, given how many of you there are. But I think this is one of the drivers for, is to try and create a system where you can go outside and say there's this problem. We're having problems with our pumps in the ICU. What does that tell us about the procurement of technology? Who's involved in that? Yeah, so I guess it's is that we're trying to lay the groundwork and the bones for that system, but at the moment it's quite tricky, and that's part of what's driven me to look at that national level, sort of about what HF capacity do we need, how do we engage with it, what problems are we having that are really good beachhead problems to sort of show the value of HF and to create demand. So we're trying to get a Falls project at the moment with an HF lens because it's a recurring problem. That it was one and done with quality improvement, and now it's recurring. And so we're trying to look at what is it about our systems that mean that we're not updating, we're not able to adapt to these changing demands in our systems, and we're seeing the same problems reoccur. So I think it's not easy at the moment, but you can see the value. And I think one of the things as clinicians who see the value in HF, like Neil and I, is to go out there and speak on behalf of and to use our power for HF practitioners to come into healthcare, to say this is what we need for our staff. I think the other big lens at the moment is that there's an international workforce crisis after the pandemic. We've lost a lot of staff, and everyone keeps talking about recruitment, but our bigger issues are more about retention and burnout. People, the moral injury of not being able to provide good care in the setting of a system that's kind of overwhelmed globally. And I think that focus on designing for well-being this is the time for that. You can go and do a pizza and yoga course, that's awesome, but if you return back to the same poorly designed, non-supportive, mad systems where you're required to do work that doesn't add value, then it's still going to create the same problems. And so once we've framed that as an organisational impact, we can start to think about, and how do we design it differently to support staff wellbeing? So I think HF has got many things that are brewing at the moment that really show its value. And I think as clinicians, we have to kind of both use our own HF lens and skills, but acknowledge that those are limited, and then to partner with practitioners to come in and provide proper HF tools and things. So, I think that's the way forward.
Yeah, I think you're right, actually, Carl. And it's getting a recurrent discussion about the value of human factors. The discussion about resilient healthcare, thinking about what goes well, what we could do differently rather than what went wrong and what we could do better. And it's really interesting. I don't know about you, Carl, but I find the most difficult nut to crack is your own home base, your own hospital, your own area. I sort of bored people to tears with, safety 1, safety 2, resilient healthcare, et cetera, and we had somebody in the other day, Paul Bowie. Do you know Paul Bowie, Carl? And so he came in and gave a talk about at our critical incident meeting, because we're worried and realizing that the way that we're looking at incidents is very deeply flawed. And in fact, I think in pediatric intensive care is one of the, I'll say it is one of the most dangerous things that we've got in intensive care, because It is looking at a superficial, if you're looking at something very complex, very superficially, applying a protocol or a guideline or a constraint immediately that then will potentially bring two parts of your system together that have never been there before and create another problem which is unseen. And it's not taking into account of system thinking. But Paul Bowie came in at this and he talked the same sort of language as me, and it was great to see because people were listening to, somebody else speaking the same language, and they took it on board. And, I wasn't annoyed or irritated that maybe they hadn't been, listening to me, and maybe I was just boring them to tears. But I think what you touched on, Carl, is right. It's just getting more and more people talking the same language, discussing the same points. There are different ways to do this. We shouldn't be changing everything. I think we should just be expanding our lens rather than ignoring the stuff that's gone before. People who have been, looking at, purely like sort of safety one, looking at what goes wrong and then thinking that's a barometer of our system. That's the way that they've been taught, and that's that we shouldn't be ignoring that. We shouldn't be annoyed at that. We need to work in partnership with everybody. So I think home base is the biggest difficult place to crack, but it's fantastic when other people can come in and speak the same language, and then slowly there's just a group of people who are just talking in a slightly different way. I think initially when this sort of stuff came out, then there were one or two people who were banging their chests about it and said we shouldn't be looking at things that go wrong. You've done it wrong for 20 years. And of course that just switches people off immediately, and the patient safety program within each individual board or hospital are full of good, well-meaning people. It's just trying to maybe get their skills, gifts and passions, see what they're about, and utilize them in just a very slightly different way. I always remember Steve Shark saying, if you could look at the incident, 95% of it in safety one, but just maybe 5% in safety two, what was it that is good about this? Why has it never gone wrong before? Then you just begin to just change the focus very, very slightly.
Oh, I was just saying that safety one, safety two division, do we look at bad incidents and stuff? It's kind of, I must admit for me now, I just sort of say, what we should really be thinking about is what was so usual about this case? What does this case tell us about the usual trade-offs, goal conflicts, constraints, ability to cope in our system? What's so normal? What can we learn about it? And so we have taken that kind of idea, and so and that's kind of to me, the safety two is not just learning from what goes well. It's about this idea of there's no special cause for failure. There's not a special reason why things go wrong. That it's about our ability to match conditions is what keeps us safe. And so, what is it about the conditions that meant that we weren't able to match them? And I think that lens is really useful. So we've started that with our case reviews, and and nationally moving to more learning reviews. And it's the same, I think, with the UK. Is trying to really understand about these kind of usual constraints. And we had a case where we had quite a nasty complication of procedure, and you could actually track it down to the dysynchrony of the team coming together in terms of the demands that were going on the service at the time and the layout of the room. Like the physical layout of the room meant that the jobs that were assigned couldn't be done, and so you could explain the behaviour almost entirely through these two things. But whereas normally we would have said that trainee had bad hands or you weren't supervising, and so we're now having conversations about how do we take control of space rather than have the space control us. So I kind of think there are this way of thinking about how we are shaped by our systems, by our environment, tools, whatever. Is really useful both in incidents and in design, and it kind of affects everything. And I think that that's something you can weave into. It changes everything. It actually changes everything. But it's about how do you, as you say, keep talking about it. And we've brought Paul Bowie over to New Zealand, or he's talked to us, and Ken Catchpole, and so yeah, we're not above having people say the same things with a different accent either. So. It can be very useful. I think one of the things we have to watch out for those is that consistency, and we've seen some people in healthcare, who are putting themselves up as human factors experts, who are talking about complacency and not losing situational awareness and drinking water. And these things are, human factors is about people and systems. It's not just about individuals. And I kind of think, we have to be really clear, and whoever is clinically talking about this, about are we aligned with, what human factors really is. It's long history, and it's the views that it brings to people and systems, I think. And that's something that people like you and I, Neil, have to go out there and be very clear about. What is this thing we're talking about? Because I think there is confusion still.
Yeah, there is. And I think it's probably maybe historically our desire to make things safer by just adopting a single sort of process or whatever in the form of QI. I mean, I think QI definitely has its place, but we were kind of warned about this 2.5 decades ago. If you want to improve patient safety, there are several things that we can do, but A, don't use QI in isolation. B, don't go it alone. Please use ergonomists, human factors engineers, psychologists, social scientists. And whatever you do, do not use human error as a reduction in human error as a marker of success, because it will inevitably fail. And that's exactly what we did. So we're quite far down the rabbit hole, I think, of using this as a barometer of safety. I think sometimes I get the feeling that a critical incident done, how many times can you get a critical incident done on time, and how many recommendations can you get from that, is a barometer of how safe your institution is. Whereas some of the best, I got this quote the other day, there's a good or a thorough investigation will gather dust on a shelf. A really thorough investigation will hold a big oak door open in a hurricane. And just because of the depth of pages that have been actually used, which nobody ever reads. And some of the most impressive incident reports I've ever seen say we should change nothing. Just like the Dave Holworth days, that the system's too complex for us to understand. And this is a once in a lifetime event for any of the physicians that were involved. It's never going to happen again. We don't want to align this with the person standing beside the problem. The historical gestation of that was 3 years ago, and just pushing and migrating the risk rather than mitigating it. So I think thinking about human factors and just articulating that just softly and gently and recurrently and in ways that people understand, and it's not complex, and it's not saying that people are wrong and they've been barking up the wrong tree for so long. I think you're right, Carl. I think the time is now for us to just gently, change the lens of how complex systems work. But I do worry about the fact that we've adopted a single way of looking at safety. And then that has created anxiety, worry, shame, second victim phenomenon, all these types of things, which is then affects your well-being of your entire system. It affects your retention, your recruitment. So the other thing we were talking about, I was speaking to some of my PICU colleagues in the States the other day, and one of them came up and said, how do you measure nothing happening? And I was going, well, I don't know. I have no idea, but wouldn't that be a great metric to actually measure? Because, often when we come out of PICU, the only thing that I know when I go there is my start time, 8 o'clock in the morning. That's it. Most of the time I can come out after 13 hours, I can switch off, I can get on my bike, I can go home, because nothing has happened. Now, plenty of things has happened, but nothing's really happened. And why is that? Why did nothing happen? And I remember Steve Short talking about that, don't aim for zero, aim for nothing happening. And I think nothing happening in a complex world shows you that the safety in the background is silent, but it's silent and invisible, and so we're not drawn to it. We don't examine it. Why does work? What was your normal day's work today? And that's, I think, what Carl's touching on is just your everyday work. We should be looking at that, and that's when human factors engineers are going to be so important. And in Scotland, I don't know of any real human factors engineers who are incorporated into healthcare. But it's about time that we should be thinking about changing that for the reasons that we just discussed.
Just to pick up on that, Neil, you said you don't know of any HF specialists that are really integrated in healthcare. What's the situation, Carl, like in New Zealand? Are there human factors specialists embedded within trusts?
No, so The last 3 years have brought a bit of change. We had volcanoes and pandemics, and now we're having a major health reform. We're going to a single health system, which will be interesting. And the organisation I work for, the Health Quality Safety Commission, is kind of adjacent to that. It's sort of has a monitoring and a capacity building place within the system in terms of quality and safety. And so we've been building HF capacity, and we're now trying to look for those opportunities for this new big singular entity to really embrace HF practitioners and to embed them. But no, not currently. And it's been, we have an HF community here, and they'd love to come into healthcare, and they want to do it, and they're waiting for the door to be opened. And we have so many QI practitioners, nurse-trained QI practitioners, and that's kind of of course everyone does that. And we've just now recreated an HF pathway for, a kind of introductory HF to a postgraduate to a master's kind of level. So we're now trying to create that vocational pathway as an equivalent. But no, we're not there yet. And I think that's compared to somewhere like the States, where there's this regulatory requirements to have HF involved, I think it's we're not there at all. And I think I'm hoping that the WHO patient safety strategy will put some heat in it. But my worry is that, HF will be seen as, HF can sometimes be misinterpreted as team training or, all the other things that we've seen in healthcare. That kind of speaks to, I guess, another problem which is related, which is that one of the risks of people who are interested in HF, who are clinicians, is that they think that's enough. And I think we are good as bridges, but we're not practitioners. And I think healthcare in general tends to have, I think we often embrace things and feel that we understand them at these very deep levels. And I think we know enough to be able to explain what a concept is and what it might bring. But I think it's important we work in those partnerships to say, and here's someone who knows a crap load more and can spend the time, and I think that's the way forward, that partnership. But no, not currently, not in New Zealand. We're working on it, slowly.
Do you have HF training in medical schools, out of interest, in New Zealand?
Depends what you call HF. If you're talking about systems thinking, some, not much. If you're talking about interdisciplinary work, yes, some. But I guess is that one of the difficulties with the medical school training is, that has to be coherent with the way people work every day as well. Like if you're going to talk about systems and interprofessional working and then you're not going to model that when people hit the ward, then you might as well have not bothered. It's so I guess is that what we're trying to do is to do that with the med schools, but also to, on the wards and stuff, get people to look around and see their actions, to see how they are embedded within systems. It's really hard though. I don't know how you find it, but we're finding, with nursing, there's more and more push to electronic checklists, to, have you done the scoring system? Have you done the list? We're more and more thinking about tasks, and we're not really getting people to think about themselves and systems. And most of our structures are set up to respond as individuals, not as individuals situated in the system. And that includes our medical legal systems. All those things are all set up to, did you do the right thing? And so you have to take it, I think, at these multiple different levels: the med school, the hospital system, the human factors training and capability and capacity building, but also engaging with medical legal, engaging with your patient safety national sort of programs. I kind of think you almost need that system ergonomics approach to HF as well. To how do you bring in HF? You need a kind of systems approach to that.
Because it is the most complex socio-technical system on earth that you and me work in, and it's just remarkable how we are not sort of starting this sort of discussion off the minute that the medical and nursing students start, and instead we go down this route where people then go off and sideline from either medicine or nursing into clinical risk departments and all these sorts of things. But I just worry that the training is just not good enough. It's not adequate enough, and it's a shame. Did you see Matt's letter to the editor in the New England Journal recently? I mean, so there was I think it was the safety of inpatient healthcare, It came out in New England Journal in January, and it basically just said that there's quite a lot of stuff which hasn't changed with regards to patient outcomes, despite a huge amount of patient safety initiative. And Matt Scanlon, a colleague of ours in Milwaukee, wrote this along with Ken Catchpole. The final part of his letter to the editor was, I'll just bring it up. I've got it here actually. Here we go. Whereas the use of non-experts to provide clinical care would be viewed as negligence, the use of non-experts in patient safety is the standard of care. And I thought that's actually a very interesting and probably quite correct statement. Well-meaning people wanting to do their absolute best, but are probably not quite trained in the way that they could be, or certainly not trained to the standards that you are in nuclear industry or shipping or rail, etc. And very often the path runs cold, or you see something that looks so familiar it must be true. Job done, move on. So yeah, it's fascinating. And the other thing I think which is important, which we don't look at, is we come out of medical school and nurses come out of nursing school, and together we're thrown together on the first day and expected to work together in a harmonious way and solve all these problems. And we go into battle together every day in PICU. We work together, and it's so everybody's vulnerable. Everybody's doing their best, often in a situation that is completely unique. And yet the way that we are trained and the way that nurses are trained is actually quite different. And the way that I remember one nurse said to me, do you realize it's very difficult for us because we're allowed to go up to the glass ceiling and you guys are tap dancing on the top of it, And so there is this, capacity, there's this very different way that we are brought up, very different ways of how we look at things, very different ways of what we're allowed to do. And yet we have to come together and work together. And I think that's a vulnerability in our system. And I think that, potentially, medics and nurses should be learning together, far more than we're actually doing, because creating that lens, creating that different eyeball, creating finding out about skills, gifts and passions, creating the societal element of it, the trust, the thing that needs to be safe, which is the two-way communication, the two-way feedback between your staff members in a crisis, so we can manage surprise together. But I think it's something which we should be looking at. How do we integrate nursing and medical schools much more together, so we are happier to work with each other, know each other's limitations, know each other's boundaries, what's safe for them.
And I suppose you had an insight to that, Neil, when you did the nursing shifts. That was, I guess, as close as you could get to that education together. You sort that out, but that was a very conscious decision rather than a natural process that happens through the training of nurses and doctors.
Yeah, and and everybody has a different way of looking at things. And it was remarkable when I did my cleaning shift with Phyllis, and people forget, if it wasn't for Phyllis, our entire unit would be shut, today, because it wasn't clean. And when I was doing all these things, the thing that really, really struck me was people who I'd worked with for 20 years, medics, anaesthetists, surgeons. They were walking along the corridor. We've got two units and there's a adjoining corridor, and they walked along the corridor, and I had this sort of superpower of invisibility. Everybody just walked straight past me, and the only thing I did was take a step forward and say what these, valued healthcare members always say is, I'm sorry, I'm in your way. And that was a real insight into how other people, this is sort of silent hierarchy. And yet these guys, I remember being taught by a cleaner telling me that the reason that the baby on the resuscitator wasn't getting pinker was because I hadn't switched the oxygen on. And I remember that from when I was a junior doctor, and I had a good rapport with her, and she came up and told me. And so she saw something that I hadn't. And it is getting as much information as you can in order to overcome uncertainty. And we have this unhealthy, I think, reliance on certainty these days, to overcome uncertainty or to manage uncertainty, to be happy with uncertainty, to manage surprise, and to sort of navigate complexity, whatever we can see of it, and just be malleable to the ever-changing conditions of work. So yeah, that's always struck me, that we grow up together but very differently, medics and nurses.
But that can be a strength sometimes. I mean, the hierarchy stuff, we have Mama Tai, our cleaner, there's nothing invisible about her. She'll let you know she's there. But like when we talk about this HF work I do in my unit, I don't do that alone. I do that with an amazing nursing team who I work with a colleague of mine who's the most natural HF practitioner, that I've come across, who doesn't do HF, but he's, basically, when we're designing courses and stuff, he's the kind of person I have in mind. He just thinks in systems and thinks about how would I do that 1% better? How could I change that? And he's one of our educators, Helmer. The fact that we see things differently is great, because we have different perspectives on these problems. And I think the hierarchy thing, I agree with you. I think, smash the glass ceiling and all have a beer together. But it's the fact that we come from different places and have different ways of seeing the world can be a strength. It can be a requisite variety.
Yeah,
and I think, and it's about how can we come together and do this work? And I think there's some fantastic natural systems thinking, human factors kind of people out there. And it's about how do we identify them and see them and channel them and create space for them to do awesomeness,
Yeah, no, definitely. And I think that variety is so important. And some of the best doctors I've ever met are nurses. They're just so good, so intuitive. But I do just think that as a group of individuals, maybe we could integrate earlier and just see how each other work earlier, and that, because you're right. I say some of the best doctors I've ever met are nursing staff, and they're just absolutely stunning in every way.
I do think, we're kind of training for competence and wanting expertise. Do you know what I mean? Like, and particularly in nursing, the PICU nurses and ICU nurses that we work with, they're experts. That they've been around a lot. They know, they can tell you who's not right. They can help you out and say, "Are you sure you want to be doing that? Maybe you should have a sleep right now, Carl." I'm sorry, I can't understand you. You're mumbling. They'll say, So I think we kind of our systems. We've got to think a bit broader about, if we want people to think in systems and to be innovative and to think about how they'd redesign it, then we probably don't want to train them through just purely about competence and following the rules and doing these things, or we might start with that, but we leave that space open for, and now you're aware of the systems and now you know that, how would you make them better? And I think that invitation, that space, creating that space for people to think about, and how could we do this even better? But I worry that we're kind of stuck in there is a singular truth, and if everyone does it, it'll be okay, and how we are is how it should be, rather than and how could it be better every day? What's 1% we could do better tomorrow? How could we design our systems to make it just that bit easier? What are you struggling with? How can we fix that?
Because if you ask people and you talk to people, which is what I'll often do, they'll tell you, they'll have 101 ideas.
Yeah.
But the chances are they've only discussed it amongst their close colleagues, or actually maybe never discussed it with anybody, because they think, there's no point. Nothing's going to change. I'll best not speak up.
But we say we want innovation, but we value competence and compliance. What are the spaces that you have as a team to come together to talk about stuff? We do simulation. That's a reflexive field, essentially. But what else? When do we come together to talk about stuff? And so we'll routinely, now debrief events that went well. Okay. Did everyone know what was going on? Did we know it was? How did it go as we expected? What were the surprises? What do we have to work around? What made that difficult? How could we do that, differently? Even if it goes well, you make visible the fact that people are doing this work, but you will also highlight the sort of the things that they've overcome. And so I think that constant, that providing space for people to reflect on work, to come together and talk, is a really useful way of improving the system. But I don't know if we value that in this sort of setting of just churn through the numbers and get through and keep doing the same old thing faster and faster.
That's right. I was going to say, have you ever tried generative debriefs, Carl? They're weird, but they're very interesting, as in, so 8 o'clock in the morning, you'd have your discussion, and then at 9 o'clock at night, we'll maybe ask people, well, how was your day? And, inevitably it'll start off good, but then inevitably it'll also maybe deteriorate a little bit. So, people will say, well, the ward round went well, I got the discharges done, we had a good discussion with the parents. I missed that intubation, I got it on the second time. And then maybe the wheels started to come off just after lunch. In fact, the whole thing was a dog's dinner. But if you ask people at 8 o'clock in the morning, what would you like your debrief to be in 13 hours time? Well, that's quite different. It's very unlikely that people are going to say, I want the ward round to go well, I want the discharges to be fine, I want the parent discussion to be okay, I really want to miss that intubation, I really want to get it the second time. In fact, I would quite like the wheels to come off the whole system right after about lunch, and I want the whole thing to be a dog's dinner. So we've done this a couple of times, and it's really fascinating how it identifies that everybody wants the same thing. There is a sort of a common goal which is good patient care within the unit. There are certain things which are highlighted from other members of the team. So there's medics, there's physios, dietitians, nursing staff. What would you like to have, be your debrief tonight? And it's fascinating because it reveals, you don't boil the ocean, you don't have to change much, but there's one or two things that just come out of that discussion that people hadn't thought of, that you can then change and get the successful outcome and successful day of nothing happening in 13 hours time. And it's really remarkable. I mean, people look at you as though you've just grown a second head when you sort of bring this up, but it is thinking about how to generate success. And if you're wanting to generate success, you will be positive about it rather than negative. And it's creating that sort of positive outlook for the day, having that trust, having that open dialogue, having that situational dependence, psychological safety, call it what you will, but you've created the idea that we can create good patient care in 13 hours time. And it's really very, very interesting how you can do that.
Kind of ties in with that approach motivation, isn't it? Rather than saying, don't let this thing happen, you're sort of saying, well, what do we want to achieve here? What's going to, what is our goal overall? How are we going to do that? And then you can bring in that whole sort of, what do you need from this? What do I need from that? How do we line these things up in a way that makes sense? Where are we going to struggle? So I think that anticipatory focus is, I think moving away from tasks to goals and thinking about the anticipatory sort of flow of that day. I think that's definitely how we've moved now to our ward rounds. Much less about, check micro, check the x-ray, talk to families. It's more, what is it we want this day to look like? Where do we think we'll be by tomorrow? What do we need to do to make that happen? How does this impact? That head foot interrelating idea about what other parts of the system are affected by these goals and actions. I think, but that's kind of, I think, because you think in systems, that's the way you'll start to think about, what do people need from me? What do other departments need from me? What are we doing together? What is this care we're building together?
Yeah, it's really fascinating. We had a child who we took home for a compassionate extubation, and myself and the fellow did the debrief before we left. And we said, this is what we want to happen. We're working, it's probably going to take about 6 hours, taking them home, extubating them, palliative care team are there. We will come back and then we'll hear what the outcome is going to be. And we identified 3 or 4 things that we hadn't thought of in order to make it successful. And we used every single one of them. And we came back and we had the debrief that we wanted. And that kind of really brought us home just how effective and how powerful that can be, to have an effective day where nothing happened. No surprises.
That's a good day. And just one question to finish up on is, we've talked about what does good look like? What does a day look like when nothing happens? So I want you to think ahead and imagine that in 2-3 years' time, human factors in your organisation is looking pretty good. So how have you got there, and what does that good picture look like?
I've got a pretty clear idea on that one. So there's a beachhead where we start using projects that are difficult to solve problems, and we bring in HF people and we show them the value of that. and from that kind of single event, we then commit to having an HF practitioner dedicated to be part of that team, to work in relationships and to be a contact point. And from there, not just that one person, but as part of a wider system, we start to grow the knowledge and understanding of HF amongst the service, the team, and start to see the kinds of problems where HFE can really be involved. And I think that an HF practitioner, my worry is that that if they are HF for an organisation, it's not doable. So it's about how do they become a resource to grow the capacity and capability of the services. How do they get the lens in there? How do we get it so that if there are true problems that are really good for an HF project, we can then bring those ones up. How do we form the relationships with the academic sort of HF projects and training pathways that people are doing projects in healthcare, and we so I guess what I would want to see is that feedback loop of showing the value and getting more attention and resource, and that kind of, and I think so for me it would be seeing the seeds that we are planting now grow over the next few years, both in the understanding and demand from healthcare, from the capability and capacity within HF practitioners, and then the development of the relationships that you need over a long period of time to work out, what are the problems we want to work on together and how do we help each other.
And Neil, what's your vision? What does good look like?
I would love to have a HF person designated to ICU, because I think that if you've got one, it will start off inevitably as one for the hospital, but that's such an enormous undertaking. I mean, it's huge undertaking.
Yes.
So how do we start that? Do we just generally see if we can fund one for a department and do precisely what Carol has just said? See if we can actually demonstrate its utility, get people thinking about complex systems, get people thinking about the interdependencies, showing, and to a certain extent, the whole thing about, getting systems to work in my world. The catalyst is, kindness and compassion, and looking out for each other. And can we make our days easier for people to come to work, raise their hand when they're worried? But I think that having somebody like an HF practitioner integrated into our system and showing the utility of it will be just absolutely fabulous. It would be just a great thing to demonstrate. I always remember Matt saying that he described prescribing paracetamol and giving it to the patient, and they did it with a human factors engineer, and they gave up at 47 pages of A4, because they had dissected down just how complex it was, So, if you could, I wouldn't want to go that far, but I think we superficially look at our system, and human factors engineers can look a lot deeper.
Someone's going to have to take the first step and fund it, though, eh?
Yes, exactly.
So we need to make sure there's practitioners there, and then we need to make sure that people are willing to employ them, and you've got to work on both those streams.
I do think it would be easier for them if we had a better sort of, nursing and medical schools, whatever, just started to touch upon it, to have a sort of a basis about it and what human factors is, and crucially what human factors is not.
Yeah, and I think Paul Bowie's work and Loughborough's work on that is really good in terms of trying to increase the sort of vocabulary for human factors out there.
Yeah,
and I think that recognition of when things are an HF problem, I think that's and knowing where to go and having relationships to call on, that's the next step.
And I'd like to add one thing to your visions, which I think are fabulous. I'd also like to add being, and this is very much coming from the position of being a human factors specialist, is making sure that when you do have your HF specialists embedded in your organisations, whether they are in your department or whether they are at a broader position, that they are adequately supported, because you are often on your own, which can, depending on where you are in your career and your level of experience, can be a very lonely place, and can also be a very daunting place to be. So I would also like to see that we get these people in, which is brilliant, but we also give them the support to succeed, so that they as individuals succeed, but that also the whole experience for the organisation is incredibly positive, and it leaves them wanting more HF, more expertise, because it's a really hard job for people to come in and sort of get that going or change perceptions. So I'd like to add that in.
Yeah, and I guess that's the two things, isn't it? It's the mentoring of senior HF people for people starting their careers, and then is the integration in a team to say, we're glad that you bring this new lens. You're part of our team. How do we support it and make use of it? Is that two?
Absolutely. I mean, I've been a sole practitioner in a large NHS trust. For the majority of the time there, I was in one particular team. Now, no one else was a human factors specialist, but I worked in a team that had a lot of knowledge, and it was a team that I could still use as a sounding board. What do you think about that? Oh, I'm not sure. That's what you need. You want to ask somebody, does this sound about right, or am I way off here? They don't always have to be hugely experienced, but they have to have some degree of knowledge, because otherwise I think you've become very kind of blinkered, and you sort of you don't necessarily grow in confidence or feel able to try out new ideas. You do what's worked or what you think has worked, and you sort of regurgitate the same thing. So I think strong mentoring from people within an organisation who perhaps have some HF knowledge or expertise, but also some strong mentoring from outside the organisation as well, to really help develop that individual and develop human factors within that organisation.
More work to prepare the ground, I guess.
Yeah. I think it's also just slowly describing to everybody that people aren't the root cause. As Heinrich said, 100 years ago, people are the root remedy. The root remedy, the solution to any problem that you have. They're not creating it; they're the ones that could solve it. But sometimes then we create that barrier for discussion, openness, wisdom, in order to make things better. My favorite quote from a parent. Who was the boy's name was Andrew, and he won't mind me saying that, but he was incredibly unwell, and he was on a heart-lung bypass machine, and he was on every drug known to man. And but 10 o'clock at night, the parents could stand up, walk out the ward, and go home. You could set your watch by it. It was absolutely unbelievable. And I just said, well, how can you do that? How can you get in your car, drive 35 miles south of Glasgow? What makes you feel safe? And he said that he's never left me. He said, it's not the way you interact with the machines at the bedside that makes us feel safe. It's actually the way you interact with each other. And that has always, remained with me. And I think that's one of the things that we should always be cognizant of. The glue of the organisation are the nursing staff. Kindness and compassion are the sort of the catalysts to your system working to a certain extent. But that is, how do we create more of that? How do we, create more of the love and intensive care between us all? Because that is the thing that actually makes it work. But the human factors, having a human factors engineer in there will be, fabulous. But it's the little subtle things that make our society work.
Carl, Neil, I could carry on for hours. However, thank you so much. You've really brought a different perspective and some absolutely fantastic insights, which are absolutely fascinating to hear, but also given me a lot to go away and reflect upon. So thank you both for your time today.
No problem, pleasure.
Wow, two fascinating people to speak to. I could have listened to them for a lot longer. I was really interested to speak to clinicians and to hear their perspective, their experiences and their thoughts about applying HF thinking and principles into their own work areas. Hopefully you found that interesting too and given you some food for thought. See you next time. Bye.